Hey, good afternoon. My name is Sang Lee from Johns Hopkins University, orthopedic surgery. So I was really excited to moderate this most favorite sessions, complications. So first two topics probably is cervical spine specific, and next two topics could be general, but we can focus on the cervical spine.
So we're going to finish this session before we get to the discussion with Brian Sue on avoiding and managing complications in the ASC.
By the way, the best way to avoid complications, don't do any of that stuff in an ASC. Anterior transpedicular cervical fixation. These are my disclosures. None are relevant except I am the chairperson for our surgery center, Marin Specialty Surgery Center. Who here does outpatient cervical spine surgery? Interesting, not that many. So in the last 10 to 15 years, there's been a huge boom in outpatient cervical spine surgery. It's been written in the literature quite a bit, in our literature. Unfortunately, it's also been in the layperson's literature. This is from USA Today. This surgery center is in Fremont, California. It's about an hour and a half away from our surgery center. I know the surgeon. I know the surgery center. This patient had an ACDF. The spine surgeon left for the day. 4 hours later, patient couldn't breathe, died of a retropharyngeal hematoma. And so unfortunately, this is the kind of stuff that is in the news. And I would say for the last 10 years, I've been doing outpatient cervical spine surgery. 4 years ago, we built this center in Marin. It's 14,000 square feet. It cost us $12.5 million to build. It's a big, beautiful center, and when you look at the ORs, you would think, man, I could do any cervical spine surgery here. I could do front-back cervical spine surgery. I have all the stuff we need. But certainly, just because you can doesn't mean you should. And I think we'd all agree that the best way to avoid complications in ASC is to pick the right patient and to pick the right surgery. So for now, I limit my ASC cases to 1 or 2 level ACDFs, 1 or 2 level cervical disc replacements. I do foraminotomies. I know there are people that do laminoplasty, 1 to 2 level fusions. In general, I don't do those. There was a good paper in Spine that it was a Delphi analysis that took spine surgeons, orthopedic neurosurgeons, anesthesiologists, nurses who said, who are the best patients to do this in, who should you not do this in? And in general, the consensus was if it's over 2 levels, if there's OPLL, if you're gonna operate more than 3 hours, probably not the best idea. High BMI, ASA more than 2. And if they lived 30 minutes away from a hospital or they lived alone, probably not the best idea. So there's lots of complications that can happen with cervical spine surgery, as you guys know. I'm going to talk about the ones that can often happen at the surgery center that, one, are going to stop a patient from going home, so that's too much pain or they can't swallow, dysphagia, and obviously the dreaded retropharyngeal hematoma, which is going to kill a patient. Everybody has EROS protocols. You have them at your hospital. If you have a surgery center, you probably do have them as well. EROS protocols are meant to enhance the patient's care, get them to go home quickly, control pain. And when I review all the EROS protocols in the literature and we look at our own, the one thing that I see in our own that I don't see in the others is the use of ketamine and magnesium intraoperatively. So we have an anesthesia pain guy in our practice, and he helped us develop our anesthesia pain protocol. Ketamine and magnesium are very interesting. There's NMDA receptors that are associated with pain in response to injury. Activation of NMDA leads neurons to be more responsive. It's called central sensitization. So there's lots of stuff in the pain management literature to suggest that intraoperative ketamine and magnesium act on NMDA receptors and can reduce morphine usage. This is our current EROS protocol. It's probably very similar to what you guys have, but for us intraoperatively, the biggest difference I see is before we make incision, as part of my timeout, I always say, did you give 20 of Decadron? And you'll see this is for swallowing issues that Greg averted to. It's also good for pain. We use it for our lumbar patients. So I just remember it very simply as 20, 20, 10. 20 of Decadron, 20 of magnesium, 4 milligrams of mag sulfate, and these are all boluses. Now, what about dysphagia? Dysphagia is one of the most common things. It's obviously an expected thing with ACDFs, and Greg did talk about this. This is topical methylprednisolone. Swallow scores are better, and you're right. Here's Dan Rue's paper on esophageal rupture. But this is a good paper. This was a CSRS-funded study looking at saline versus IV steroid or Decadron, and this is why I give 20 of Decadron for dysphagia. There was reduced dysphagia on post-op day 1, 2, up to 6 months. And there was a very good meta-analysis in JBJS looking at 7 randomized control trials that show, in fact, IV steroids do reduce dysphagia. So if you're not using intraoperative IV steroids, you probably should be for dysphagia. And lastly, let's go to the retropharyngeal hematoma. This was a survey of surgeons who said that the impact of a single death cannot be understated from the prospective cost as well as surgeon willingness to send a patient home early, in reference to the danger of retropharyngeal hematoma and outpatient ACDF surgery. And obviously this is what we're trying to avoid, which is you have your airway and the blood pools and the blood pools and the blood pools, patient can't breathe, ends up getting intubated or dying. So what are the risk factors for retropharyngeal hematoma? And what is the incidence? In general, it's very, very low. It's less than 1%. All of these patients ultimately required surgery. 65% of hematomas occurred within 24 hours, which is very interesting to me because a third actually occur after 24 hours. And in fact, if you're doing outpatient surgery and the patient goes home after 4 to 5 hours, most will occur with the patient at home, indicating to me that this is all about patient education and who's living with the patient. Have to educate the patient, have to educate the person that's living with them. If they're having difficulty swallowing, breathing, or they have stridor, they need to call you. For that reason, particularly for my ASC patients, those patients have my personal cell phone. I tell them if there's a problem, I need a phone call to my cell phone because that's going to save a person's life. Most paravertebral swelling, and this is consistent with the last slide, in fact happens after post-op day 1, not just in the first 24 hours. So again, patient education is key. They've looked at risk factors, OPLL, long surgery time, multiple levels. The symptoms of retropharyngeal hematoma, I've had the unfortunate instance of having 2 of these. One was a 3-level, one was a 4-level. Both occurred at the hospital, not at the surgery center. So unfortunately, I do have experience with this. Patients complain of anterior tightness. Patients get very, very agitated. You have to examine them, take the whole dressing off, take the collar off, and actually feel what's happening. Drain output, I think, is completely unreliable. And stridor and drop in O2 sat is often the last to present. You can't ask the nurse, what's the O2 sat? And if the O2 sat's 90, 95, you think they're fine. That drops really, really quickly. By the time you're to the hospital, the patient dies. Oh, the sound's not coming through. We have Donald Duck without the sound coming through. I guess you can't have sound for this. Everyone knows what Donald Duck sounds like. The reason I put this up is because both of my patients, if you think about it, it wasn't stridor, it was in fact a change in phonation. And it makes sense because if you just deviate your own esophagus, if you just do that for like 2 centimeters, that's what you sound like. So both, I know you guys are gonna try that up in your hotel rooms later. So both patients sounded like that. So I asked the nurse, what does the patient sound like? How do they phonate? You ask your residents, do they sound like Donald Duck? Because if they're sounding like that, you're at risk for a hematoma. So I would say clip or tie the vessels. Patients often have hypotension when you're operating. You want to slow the bleeding down. At the end of the case, ask the anesthesiologist, are they normotensive? Because if you bring them back to normal tension, you're going to see bleeding around the longus colli, these tiny little bleeders that you may not have bipolied. After final irrigation, I'm really obsessive about bipoling everything around the longus. I know people wrap the longus colli in Surgicel, use liquid gel foam. I think the lesson here is to take that added time to really make certain that you have good hemostasis, particularly along the longus colli and around the bony bleeding surfaces. As soon as a patient's extubated, I have them elevate the head, and even when I'm closing, I have them elevate the head to reduce bleeding. And often topical vancomycin, I use that for infection, but sometimes you put vancomycin in, and I do feel like that can also help with hemostasis. Drains, they've actually shown that drains don't make a difference. I'm not sure why. I still use a drain, partly because I'm a paranoid surgeon, and also because I think there's very little downside to using a drain, but drains have been shown to actually not quite be as helpful. This is part of the CSRS educational pamphlet, and this is no scare protocol that Rick Sasso championed, and this really looks at how you manage airway problems. So at the surgery center, first you try to intubate, and you only try to intubate once. You do not try again. After that, you open the surgical site, take the hematoma out, try it again, fail number 2, and you do a crike. On the CSRS YouTube channel, we have a CSRS YouTube channel. It's a great video on how to manage hematomas and how to do a crike, so I would encourage you to watch that. We don't have to go through that. So no strikeout says you have to wash them for 4 hours after ACDF at the surgery center, discharge them only if they have competent support at home, and the no strikeout protocol. At our surgery center, we say that the anesthesiologists, they are not allowed to leave the building until that last patient leaves. They're almost always the first or second case, so they can stay 8 hours if they need. We require the surgeon to be an hour away so you can reach the center, and before discharge, nurses have to check phonation and they have to check abnormal swelling. So in summary, I would say you can avoid complications by being safe, patient selection, consider ketamine and magnesium, Decadron for dysphagia, have a well-rehearsed, well-documented plan, no scare protocol, and always have immediate coverage, not if just by yourself, but by another surgeon if you're doing an ACDF. Thank you.
So thank you, everybody, for those great presentations. We're going to open up for questions. Maybe I'll start, since you mentioned something about drains on all your ACDFs, even those that you do in the surgery center?
Every single person gets a drain.
One level ACF?
Sorry, every single person gets a drain.
How do you manage that in the outpatient?
I just have them come back in 2 or 3 days to have it pulled.
What's
It's
that?
a small 3 mm round that comes out the incision. I know some people use a Penrose. For me, it's maybe it's even more so just for my comfort. I see almost no downside to it. I think there is a potential medical, legal implication to it as well. But yeah, even for 1 or 2 levels.
And you don't let people go, you say only 4 hours, not 8?
If they're peeing, they're walking, they're breathing okay, I think 4 hours is fine. We have a surgery center where we even have 23-hour stay capability. I'm more comfortable if I do it first case, 8 a.m., case is done by 10 o'clock, they're going home at 4 or 5, so that's 6 to 8 hours.
Yeah, I think it was Dan Rue that brought this up. I don't do many outpatient ones. I keep them overnight. But we did do some during COVID in our more reliable, close patients. And, he put a Penrose drain, and what he did is safety pinned it to the gauze. And so the next day, just told the patient, change your dressing, pull the gauze off so they weren't anxious about pouring them out. So the drain will just come out with it. So they can pull it around.